Welcome, everyone, and thank you for joining us. My name is Edward Xie. I'm a board member at Canadian Doctors for Medicare, or CDM for short. I work as an emergency doctor and researcher studying how well pharmacare protects people from financial hardship and how health systems can support planetary health. I'm also a past board member of the Canadian Association of Physicians for the Environment. And my co-host Kathy is another CDM board member and a member of CAPE as well. She's also here, and she'll introduce herself a little bit later. We're delighted that you've joined us for this timely discussion. Right now, heat waves and extreme weather are sweeping across Canada at the same time as governments are rowing back on environmental commitments and investing more into the fossil infrastructure that fuels climate change. Alongside this, we've watched the federal government gradually renege on promises to establish a national pharmacare program. It's currently funded in only 3 provinces and 1 territory, and only until 2029. Affordability is an increasing challenge, and yet access to essential medicines continues to depend on our bank balance, our occupation, and where we live. Kathy and I thought that we could discuss both of these crises together in a way that highlights where they overlap and the multifaceted benefits of a national universal pharmacare program that lives up to what people in Canada deserve, expected, and were promised. We'll explore how pharmacare could have benefits to patients, the healthcare system, and the health of the planet. We're thrilled to welcome Drs. Myles Sargent and Joel Lexchin, who are our experts this evening. And while our webinar is virtual, the CDM office is located on the traditional territory of the Wendat, the Anishinaabe, Haudenosaunee, Métis, and the Mississaugas of the Credit. And as a settler, I grew up without knowledge of these responsibilities of the treaties that were formed on this land, and I now realize that this ignorance was the result of cultural genocide, which the Truth and Reconciliation Commission of Canada describes as seizure of land, forcible displacement of people, banning of languages, persecution of leaders, disruption of families, and all of that to prevent the transmission of cultural values and identity from one generation to the next. At CDM, we recognize the disproportionate and unjust disparities that Indigenous peoples continue to face today due to ongoing colonialism, including administrative barriers to accessing drug coverage and the extraction and transportation of fossil fuels through Indigenous lands without consent. We are committed to working to reduce health system inequities as part of our work towards better Medicare. I encourage you to reflect on the responsibilities and relations of the place where you're joining from, as well as to celebrate Indigenous resistance against actions that threaten the health of humans more than humans and the land. And before we begin, a few housekeeping matters. This webinar is being recorded so that it can be shared. Closed captioning is available and can be turned on. Our chat is open. We'd love to hear from you. Again, let us know where you are and whether you're a member of CDM or CAPE or both. And this event will end in about 70 minutes or so. We're going to start with a presentation from Dr. Myles Sargent, followed by Joel Lexchin. And you can ask questions through the Q&A function so we can keep track of the questions easier. We'll try to get through as many as we can. So to start us off, I'm thrilled to welcome Dr. Myles Sargent. Dr. Sargent is a family physician with 25 years of experience working with vulnerable populations, including refugees, individuals experiencing homelessness and addiction, and the elderly. He's dedicated to addressing the intersection of environmental issues and health, and in 2023, he became the executive director for the Canadian Coalition for Green Healthcare. Myles is also the co-lead of Partnerships for Environmental Action by Communities Within Healthcare Systems, or Peach Health Ontario, and co-founder of Trees for Hamilton. He is an assistant clinical professor at McMaster University. Thank you so much, Dr. Sargent, for joining us. I'll now hand it over to you.
Thank you, Edward, and thank you all for having me today. And I don't know if the slides are up yet, so here we go. Going back a bit. So starting with a visual of what we refer to as the ideal green facility, which a young architect helped draw for us a few years ago as part of the Peach project. And Edward, you did an amazing job with getting through the Peach acronym there. Most people have a tough time with that. Yes, so I am a family doctor. I'll give you my disclosures in a couple of minutes. Most of what I do now, 95%, is planetary health. I do remain at Shelter Health Network, working with men with addiction, and also do a bit of work at Hamilton Health Sciences. Next slide. Disclosures, again, I am a member of McMaster Family Medicine, so there's a bias there, I suppose, toward McMaster. I do teach the undergrads and the postgrads, and I have a .01 FTE role there. I volunteer at a couple of places, and again, as the executive director of the Canadian Coalition, I do get paid by a couple of groups for the work there, Trottier Foundation and ECCC, and I'm grateful for that. Next slide, please. So this came out 5 years ago now, and if people were watching, they've just updated this. I think maybe in the last edition of the Lancet, they've updated this, which is amazing on one hand, frustrating on the other, because I have all these numbers memorized. I'm going to have to shuffle them around a little bit, but nonetheless, this blew my mind 5 years ago. This is the footprint of healthcare in England. So if you put the footprint of all the different things we do within healthcare, and this would include ambulances, dental offices, primary care hospitals, put it on a graph, this is what it shows. So in green, personal travel, which we talk about a lot in society, accounted for 10% of their footprint in green there. Visitor, staff, and patient. Delivery of care is in red. So building energy, 8 o'clock, about 11%. That number hasn't changed. In fact, most of these numbers, just to let you know, have not changed. So I'm actually okay to continue using this slide. Most of this is the supply chain, 62% or so. And the first 22%, getting to our topic today, is pharmaceuticals. That is the production of pharmaceuticals, first 22% of the pie. You also see pharmaceuticals in the delivery of care over at, I guess that would be about 10 o'clock. The direct emissions from anesthetic gases and metered dose inhalers. That is one piece of the pie that the English have shrunk down over the past few years. Next slide. The English data I just showed, again, was a summary of all different parts of their healthcare. If you just look at family medicine, primary care, this is what it looks like. So we took their pie graph for family medicine, we turned it into an elephant. This was published about a year ago, the environmental elephant in the office. The point here, the body of the elephant for family medicine is pharmaceutical production, 48% of family medicine. And MDI use is an additional, the ear, 13%. So that's 61% of our footprint in primary care. Is pretty astonishing, is related to medications. Next slide. I'm going down a certain pathway here, which may be a little bit confusing, but I'll assure you that I'm going to pivot toward the end before I pass to Joel. So why do medications have such a big footprint? Next slide. Let's talk about the journey first. Next slide, please. This is the journey of a computer. I came across this roughly 5 years ago as well. And they were looking, really, this was around the time of COVID. So they were thinking about supply chain disruptions and why there's so many disruptions during that COVID period of getting supplies. This computer, if you look at one pathway here, starting in Chile, number 1, going across number 2 to Southeast Asia, then up number 3 into more northern Asia, then across number 4 into China for final assembly, then across to Mexico, number 5, and finally up into Canada. So that made me curious, what happens to a medication? But as we all know, big pharma is not always forthcoming with this information. It was difficult to find. I certainly couldn't find it back then. Next slide, please. We decided to look at clonazepam and try to find the journey of clonazepam. And why did we pick clonazepam? It's overprescribed, it's habituating, has several harms. There are safer alternatives. Also, it's an older medication, so we thought we might find more information about it. Next slide. We don't learn much about excipients in medical school, at least I didn't, and I talked to the medical students today. I don't think they learn much about excipients. The pharmacists can tell you about excipients. These are all the different type of excipients that you can find in a clonazepam pill. So it's not just the active pharmaceutical ingredient. Anywhere between 5 to 9 excipients go into the medication as well. Next slide. We worked with 3 engineering master's students at McMaster University, and we traced the journey of a clonazepam pill to get to a patient in Vancouver. The bulk of the production, whether it's excipient or active pharmaceutical ingredient, is in Asia, about 90%. And so that's why the pathway is so long. The total journey we found was about 62,000 kilometers. There are different ways the medication can be made. There are shorter journeys as well. I will admit we did cheat. We picked Vancouver because we saw that that would be a little bit further. We could have picked the GTA and made it a couple thousand kilometers less, but nonetheless, I believe going around the equator would be a 40,000 kilometer journey, so 62,000 is pretty far. Next slide. Before I go on, I will point out that Canada has the most supply chain disruptions of any country in the world in terms of medications and medical devices. And so this is also part of the problem. Are there ways we can make medications that don't need to travel so far? So we're going to get into manufacture next. Next slide. So while we were working on looking at the journey of a pill, a group called the MCF classifier, they also call themselves U-Maker. You can look them up, based in England, YEWMAKER, U-Maker. They were looking at the footprint of a medication by looking at the active pharmaceutical ingredient based on its chemical structure and process mass intensity. And essentially what that means is they're looking at all the bits that go into an active pharmaceutical ingredient, how much they weigh for each pill, and then estimating the carbon footprint. And then they took this, translated into carbon dioxide equivalent, and then they were able to compare medications. I'm showing propranolol here compared to other beta blockers, and I'm going to go to the next slide and let you know that we did work with them over the past 2 years, and we've translated this into a Canadian medical pharmacy model. We didn't do all the meds. I think we did about 900 common medications. If you want to check out our website, you can see. So this is pantoprazole, a PPI. Compared to other PPIs, pantoprazole happens to be much higher in its footprint than, say, omeprazole. So interesting information. Clearly, we need to be careful about telling people how to prescribe medications. It's always going to be patient safety first, but might be something you want to look at. Next slide. And then the third element to why medications make up so much of the footprint is because of overprescribing habits. Next slide. About 3 or 4 years ago now, we looked at a hospital, a standard 200-bed hospital in Canada, and we modeled what different initiatives would look like. So if you are keen at your hospital and you're starting a green team and you want to take on an initiative, which one should you take on? We looked at the carbon footprint or the carbon savings from doing a certain project, and we also looked at the cost of that project, and that's what you're looking at. The orange fruits are the ones which we call the game changers. They have over 100 tons of CO2 saving per year, again, for a 200-bed hospital in Canada. The yellow ones were between 50 to 100 tons, and the green ones were less than 0.5 tons. They all matter. If we're getting to net zero, they all matter. But interesting, sorry, if you could just stay on the tree for a second. You can look up at, let's say, 10 o'clock EV chargers. It just so happens at the hospital that I work at, we have 4 EV chargers. So what is the cost of that for us? It was about 30,000. You can see on the cost scale there, we have it between about $10,000 and $100,000. So it costs a bit of money, but it's actually a green fruit on the tree. A lot of these things are cost neutral or cost saving. And you can see deprescribing, getting back to our topic, is arguably the most important one. It's a game changer. We modeled 5%. Can you decrease the meds in your hospital by 5%? You would save $500,000. You'd likely be helping your patients, and you'd make a big impact in terms of planetary health. Next slide, please. The hospital I work at is a complex care hospital. All of our patients come from acute care and then are admitted to us to be stabilized before they go into long-term care or home. We did a QI study a couple of years ago to look at the number of medications our patients were coming into hospital on, and the average number was 19.1 medications each, which shocks a lot of people. Does not shock people typically who work in acute care or complex care. I thought it would be around this number. Of the 19 meds, 13 were regular meds, 6 PRN meds. Then we looked at where can we do better. There were 4 classes of meds that we felt we could do better: benzodiazepines, PPIs, low molecular weight heparin, and multivitamins. And so that's sort of the next phase of our QI study, to look at those and how we can improve. Next slide. Low molecular weight heparin, for example, in our hospital system gets started when someone comes in with an inflammatory disease, which could be a pneumonia, for example. A frail patient with a pneumonia who's immobile likely gets started on low molecular weight heparin. The question is, when do we stop it? Likely does not get stopped in acute care. Patient then comes to us in chronic care. They might be with us for 2 months, rehabilitating, getting stronger to ambulate, etc. Physicians are too scared to stop the medication. You do not want to be the one that is responsible for a clot. So when is it stopped? It is stopped on discharge almost every single time, whether the patient is going to long-term care or going home. That is the day it's stopped, because it's no longer covered. So we talked to the thrombosis folks and said, hey, can we come up with a protocol? And so we have. And so now low molecular weight heparin is stopped 30 days after the acute illness is finished. And this has obviously made a big difference. Next slide. So this is where I make the pivot from overprescribing to underprescribing. We wrote an article a couple of years ago called "A Kilo for a Ton," and the concept there is that a study done, I think, around 2018, looked at how we apply the guidelines as physicians. Do we overuse them or underuse? And we actually are more likely to underuse guidelines. And so one thing would be vaccines. And so the point here is that a vaccine may require a kilo of CO2 in its production, obviously the medication itself, the syringe, the needle, but then it prevents a ton of CO2 down the road in terms of preventing hospitalizations. Next slide, please. In that article, we gave 10 examples from different specialties. Respirology, we used COVID-19, influenza vaccines. OB-GYN, we used HPV vaccines for patients between 9 to 26 who are vastly under vaccinated. Next slide, please. And this just shows the impact of decreasing hospitalizations. This is from 2 years ago. We looked at the carbon footprint of a hospitalization in British Columbia. Those are the 4 bar graphs on the left, and then also in Laval, Quebec on the right. The data in BC showed that a hospitalization was about 30 kilograms of CO2 per day. Long-term care was about 8 or 9, and home care was less than 2. So keeping patients out of hospital is good for the environment. Of course, patients don't want to age and die in hospital. The interesting thing here is this graph, which is the one that ended up in the Lancet, does not show the blue piece of the pie I talked about before. This is mainly the building energy. And so if you want to look at what the supply chain looked like, next slide, you now see how small the green bars are compared to the blue bars. And we had that data from Laval. So Laval did look at supply chain comparing hospitals to long-term care, and it's just massive difference. So keeping people out of hospital is good for the planet. Next slide. Finally, lack of access. Angus Reid study done February 2026. I'm just reading from here. Healthcare access. Half of Canadians either don't have a family doctor or struggle to see the one that they have. 1 in 8 say they've been looking for more than a year and have given up on finding a family doctor. And I think we all know this impacts vulnerable populations more than other populations. And one final slide. This is something we made toolkit a couple of years ago. We called it Options for the Sustainable Prescriber, just helping us all think through prescribing. I don't want to tell prescribers how to prescribe per se. However, it is sometimes good to look at your own practice. Number one, what matters to you, the patient? Number two, can we apply social prescribing, all the different social prescriptions that we can give? Thinking about how to start a medication, much easier to start a medication sometimes than to stop it. Then we also look at medication optimization, deprescribing. Legacy medications are something to think about in terms of the overprescribing side of things, medications that you start and end up getting continued for years and years and years, and benzodiazepines would be in that list. And I'm going to pass it over to Joel. Thanks, and we'll answer your questions in a minute.
Thank you very
Great. Thank you so
much.
much, Dr. Sargent. I really love the imagery to help us visualize the impact of medications, the elephant, the supply chain maps, the dotted line for the journey of urine, the peach tree of low carbon solutions. This was great. I do see that there's one question in the chat already. Please keep those coming. We're going to get to those at the end, and I'm going to hand it over to my colleague, Dr. Catherine Cervin.
Thank you very much, Edward. And hello and welcome, everyone. My name is Kathy Cervin. I'm a retired family physician, and throughout my career, I've divided my time between Northern Ontario and Nova Scotia, and I've been an academic leader in both locations at Dalhousie and then Northern Ontario School of Medicine University. And I am a member of both CAPE and Canadian, and on the board of Canadian Doctors for Medicare. And I'm very excited to see the interest in this topic because I think there are many ways that our two organizations can collaborate for a healthier planet and for a better healthcare system. And I am delighted to introduce Joel Lexchin, who many of you will know. We are classmates going back a couple of decades. Joel has
More than a couple.
yeah. Joel has worked as an emergency physician for 40 years. So yeah, at least 40 years. And retired 4 years ago. He's a professor emeritus at the School of Health Policy and Management at York University. And for over 45 years, he's been researching and writing about multiple areas of pharmaceutical policy, including Pharmacare. He will explain how Pharmacare and the greening of pharmaceuticals go hand in hand. So take it away, Joel.
Thanks, Kathy. I'm very happy to be here and be able to present. So let's just go back to the first slide. No? Okay. So I'm going to talk about how Pharmacare can enhance the not only the access that people have to affordable medication, it can also make our job as prescribers easier, and it can help the environment. So a triple threat from Pharmacare, or a triple benefit from Pharmacare, I suppose. Next slide, please. So this is just my conflicts of interest. I get little bits of money from various places, about enough to buy a McDonald's every couple of years, and no money from drug companies. Next slide, please. So let's start off by talking about what pharmacare should be. And this is my view of pharmacare, but I think it's also the view of a lot of people who are concerned about this issue. So, first of all, pharmacare should be first dollar prescription coverage. In other words, what we already have for doctors and hospital services, no deductibles, no copays, um, and the entire cost for drugs that are listed on a national formulary should be covered by Pharmacare. The Pharmacare should be available for everybody who is legally living in Canada. You shouldn't have to register for it. You shouldn't have to send in a form to the government. If you're here, and you should be able to get drug coverage. It should cover all medically necessary drugs, and these would be drugs that are chosen by a panel of experts, including patients, um, to be covered. So it would not cover a lot of the garbage that's currently covered by private drug plans. Private drug plans typically will pay for everything that is approved by Health Canada. And finally, when we're talking about pharmacare, there are corollary effects, and I'll get into those in a little bit. So, next slide, please. So, that's what pharmacare should be. And as Edward mentioned, that's not what we have today. What we have today, through the passage of the Pharmacare Act back in November of 2024, is a very tiny step towards what I just described. So it only covers two classes of drugs: products for diabetes and birth control products. And it only is available in three provinces: BC, Manitoba, and PEI, and in the Yukon Territory. And although Mark Carney and Marjorie Michelle have promised that they're looking at deals with other provinces and territories, that does not seem to be the case. They don't seem to be interested in expanding the number of provinces that are have deals with, and also, as Edward said, the deals that are signed are going to expire in 2029, and the indications are that they will not be renewed. So even with this very limited form of pharmacare, it's been shown to have benefits. So we'll look at BC, where after 15 months of free contraception, the long-acting reversible contraceptive market grew by just under 2%, which doesn't sound like an awful lot, but probably translates into tens of thousands of women. So these are women who now have control over their own reproduction, can choose when to get pregnant or not to get pregnant. Next slide, please. So Myles talked a little bit about this. So if you look at primary care and you look at the sources of greenhouse gases from primary care, pharmaceuticals are by far the largest source of greenhouse gases. 61% of all the greenhouse gases that primary care is responsible for come from pharmaceuticals in one way or another. Next slide, please. So, drugs produce greenhouse gases through upstream effects and downstream effects. So upstream is before the drug is taken. So there is energy intensive production of the ingredients. And as Myles showed you, there are many ingredients that go into the pills that we prescribe and that patients take. And so the production of these ingredients are a source of greenhouse gases, as is converting them into a final form. There is packaging to be able to transport them from wherever they're made to where they're going to be finally used. There are the transportation costs. There are the storage costs. All of those generate greenhouse gases. And then there's the downstream production of greenhouse gases. So in other words, after drugs have been used, there is disposal of products that have passed their expiry date. We have to burn them, bury them, what have you, again, generating greenhouse gases. And we also excrete what we've taken in either urine or feces. And that those drugs go into the atmosphere, they go into the water, they go into the soil. Um, Antibiotics that are either not used or excreted um, contribute to antimicrobial resistance, which again has environmental impact, and hormones also will contribute to greenhouse gases through the downstream effects. Next slide, please. So how can Pharmacare reduce the environmental impact of the prescription medications that we prescribe and that patients take? And there are four areas that I'm going to briefly cover. So affordability, rational drug formularies, appropriate prescribing and use, and reducing the distribution of so-called free drug samples. Next slide, please. So affordability is the what people probably think about the most when we talk about pharmacare. And cost-related non-adherence, in other words, patients not taking drugs, skipping pills, is variously reported in Canada as affecting between 8 and 25% of the population. And if you don't take appropriate medications properly, what you end up with is more physician visits with its greenhouse gas effects, transportation, getting to the doctor, more emergency department visits, greenhouse gases generated through the hospital system, more hospitalizations, again, greenhouse gases and environmental costs associated with that. And finally, more morbidity and mortality, which will require more resources to deal with, and again, end up generating more and having a greater environmental impact. Next slide, please. So a rational national formulary. So as I said, the private drug plans insure about 55 to 60% of Canadians. These plans typically will cover everything that Health Canada has approved, which includes a lot of the Me Too drugs, a lot of drugs that are no better than existing products, but there are environmental costs in making those drugs. And if they're inferior in terms of their therapeutic ability, that will lead to morbidity. Morbidity leads to environmental impact. So if we have pharmacare, we're going to have, as a corollary to that, a national formulary and the national formulary will exclude a lot of the junk that is available now, which eventually, hopefully, will lead to less production of these drugs and the decrease in the environmental costs of producing them. And a better benefit to harm ratio, because we're using it's only the most effective drugs that are on the formulary. Um, the better benefit to harm ratio should encourage patients not to discontinue drug use. A lot of drug use is discontinued because of unwanted side effects or because the drugs are ineffective. So if we decrease the use of those of ineffective medications, there's less need to dispose of unused drugs. And again, hopefully, there will be less production of them over the long term. Next slide, please. So, appropriate prescribing and use. Um, and this goes to the idea that if the government is paying for the cost of prescription drugs, then it's got an incentive to make sure that these drugs are being used properly. In other words, being prescribed properly by us and being used properly by the patients. Um, right now, the systems for appropriate prescribing and appropriate use are fragmented. Um, and they're usually provincially based, so they exist in some form or other in one province. They don't exist in another province. Sometimes they're underfunded, so they're not going to be as effective as they could be. So if government, as I said, is paying for the cost of prescription drugs, then it's going to do, hopefully, again, a variety of things. It's going to invest in prescribing education for us. So that's things like academic detailing, sending around specially trained pharmacists to talk to us about our prescribing patterns, and help us learn about what's the most effective medications. It's going to promote deprescribing programs, so less use of drugs again reduces environmental impact. It'll discourage polypharmacy. It'll encourage medication review programs, and it'll encourage what's called audit and feedback. In other words, a method of monitoring what you're prescribing based on your and looking at what your population is, your patient population, and then feeding you back information about your prescribing, pointing out that you're doing a good job in prescribing, say, antihypertensives, but not such a good job in prescribing medications for asthma. So again, better prescribing means better use of appropriate medications, not using the stuff that isn't effective or is unsafe. Um, Hope again, these programs should encourage prescribers to use non-pharmaceutical treatments when those are appropriate. So you cut down on the number of drugs being prescribed, and you also cut down on the number of drugs being used, the number of drugs that have to be disposed of. These programs should also encourage patients to think about non-pharmaceutical treatments. So, and similarly to us prescribing less, patients will be encouraged to not think about drug therapy as the first line choice when other methods of therapy are just as effective or even more effective. And finally, appropriate prescribing also means encouraging environmentally friendly ways of disposing of medications. Next slide, please. So I'm sure that virtually everybody on this call has had, at one point or another, a sample cupboard. These are the drugs that are given out by the drug companies. Why don't you take these, try them on your patients, see how they help. Um, First of all, research shows that they're not given to people who can't afford them. They're given to physicians' families. They're given to people who already have access to medications. There's large amounts of money that's spent on promoting new drugs through sampling. This again, if you're giving out the newest and latest drug, you're giving out the most expensive one, and perhaps possibly giving out inappropriate medications. It encourages the overuse of drugs. Um, the people who give you the samples are the sales representatives. They travel around using gas, using electricity, what have you. There are printing costs associated with um, setting up, giving the samples. They're often overpackaged. The volumes aren't large enough in most cases, for a complete course of therapy. So you need multiple samples. As I said, the newest drugs are the ones that are sampled. Less is known about their effectiveness and safety, so they may not be appropriate. And finally, um, if we have Pharmacare, we don't need free samples for people because they're getting their drugs paid um, for, through the government program. Next slide. So, in conclusion, Pharmacare means no direct costs to patients for medications, no direct or indirect costs, improved health outcomes, and also less environmental impact from the production and use of medicines. So, thanks very much, and happy to take any questions.
Thank you very much, Joel. I've learned so much both from you and from Myles. Some of the eye-opening things were the underuse of medications causing impact on the environment, and your last comments about samples are also very, very eye-opening. So there's a lot of work for us to do to advance pharmacare and while at the same time protecting our environment. So we do have a number of questions. Claire McAllister, I see your hand is up. I wonder if you have a question. And if you do, feel free to unmute and ask your question to the panelists. And we have quite a few in the Q&A, which we will get to shortly. And also, if you would like to put up your Zoom hand and speak, that's another way to ask a question. So Claire, I'm giving you a minute to speak if you'd like. And Claire, we're not hearing from you, but I see Sylvia, you have raised your hand. Would you like to ask your question? And then I'll turn it to Edward to read one from the chat.
Unmute.
There you are.
Can you
Well
hear?
done.
Well, I appreciate your presentation. I am always was interested in knowing about the overprescribing medications by the medical system. One thing that I noticed, and I never came across a conference or someone that mentioned, but here we are in Manitoba. I am not sure if all the provinces are the same, but most of the community clinic are attached. They have a pharmacist attached. And the pharmacist is usually the owner of the clinic. So the pharmacist is the owner, and the family so is the one that decide the overhead that most of the physician pays. In many cases, when you don't overprescribe, in my opinion, but when you reduce the number of medications that you want to prescribe, the doctor is replaced by another doctor, or the doctor has an increase, somehow very subtle, of the overhead. So it's like we are a kind of hostage, no, a hostage. We are like here we have a dilemma. I mean, if we sign with a clinic and the clinic is owned by a pharmacist, which is probably, I don't know, but this is a rough estimation of myself, 80% of the clinics here. So you have to overprescribe if you want to stay in the clinic, basically. And yeah, and the overhead, I was told by a clinician, by a pharmacist, that if I have 100 prescriptions a day, my overhead will be reduced to 10%, for example. While if I don't prescribe that amount and I go to reduce the medications like I used to do, the overhead will be much higher. But we suppose, according to the colleges and the regulatory agencies, to work together with the pharmacist. So, and the pharmacist to me represent private interest and not the public interest. So I never hear anything about that. And the other thing that I want to say is that, in my opinion, the polypharmacy, when you mentioned initially that you discharge a patient from hospital with an average of 19 medications, well, there is one thing that is very dangerous to me, and is to assess the adverse event of each medication, because you can compare A and B, but if you have 19, I've seen that go exponentially. I am not a mathematician, I don't like math, but I think this is a problem, basically, which is impossible to know the interaction between medications too.
Thank you very much for those interesting questions, Sylvia. I'm going to turn it to Joel first to respond to Sylvia's first question, and then Myles, if you have anything to add.
So I worked in hospitals my entire career, so I'm not really familiar with the situation with pharmacy-owned or pharmacist-owned clinics. Um, I mean, pharmacists are a very valuable resource, and I think that there is a great deal of worth in doctors and pharmacists collaborating. And what I would like to see um, is pharmacists working in clinics as professionals. So you write a prescription for a particular product. You can see that your patient is already on 3 or 4 medications to begin with, and you can send them down the hall for a consultation with the pharmacist to discuss what to look for in the way of side effects, when the medication should be appropriately taken, what to expect from the medications in terms of how efficacious they're likely to be. So that would be my vision for an ideal relationship between physicians and pharmacists.
Thank you, Joel. And I think, Myles, I'm interested in your thoughts as well. I think, Sylvia, you may have highlighted an area that needs more inquiry because it sounds maybe not so subtle. And if the pharmacy is a larger corporation, then we know they are very much driven by profit, and maybe it's not that practice is not widespread, but it's a very interesting point you've made. Myles, do you have something to add there?
Um, I think so. I guess you can judge after I say it. But first of all, the comment about I think it was Sylvia said that in Manitoba it might be as much as 80%. I hate to sound naive. I am shocked. Oh my gosh. I don't think that, look, I'm not in a private practice. I've always worked in community health centers or other, things like that. But um, mm, I think that in Ontario, and please correct me if I'm wrong, and Edward, you might have some ideas here. To me, that might be a walk-in clinic model. Is that fair? I mean, that's just kind of what I'm thinking. But I did not think that was a big issue. So very, very interested to hear that. I think it's something we could all potentially look into. I'd love to know what those numbers are. Really, really surprised to hear that kind of influence on physician prescribing behavior. The thing I hear in Ontario is the frustration from physicians where they might, um, you know, go to, it's not easy to deprescribe meds. Sometimes it takes a lot of education and work to deprescribe a med. I mean, especially as a primary care doc, someone's been to the specialist said, you know, start these 3 meds. They're on 15 meds. Yet now you've got to say to your point, Sylvia, there's a lot of drug interactions here, and we should probably be, stopping this one. So you go to all that trouble. But pharmacists now, of course, have prescribing powers they didn't have in the past, and maybe the pharmacist then restarts the med that you just stopped. That's what I hear about in Ontario, not the influence issue. Then the other thing you mentioned, I'm sorry that in my presentation I didn't make it clear, but absolutely, patients being on 19 meds. And I don't mean to embarrass our system, but again, it's that same thing that if someone has heart disease, for example, and they see the cardiologist, they're getting 3 or 4 meds, like just automatic, bam. And you can go down every disease for some of the patients they have. This is, frail, older adults in my practice at the hospital. So they might have multiple diseases, and you get 2 or 3 evidence-based meds for each of those conditions, but then you mix them all together, and yes, it starts to go up exponentially in terms of drug interactions. So this is best for patients as well. So when I compare that 19 meds, it was interesting for me compared to that peach tree where I said we happen to model what does it look like to deprescribe by 5%. In my practice, if I can stop 1 med out of 19, that's over 5%, just 1 med. Can't be that hard.
Great. Thank you, Myles. Edward, would you like to read a question from the chat, please?
Yeah, sure. And I'll add on to what Myles said because I think that was a really valuable answer by both Dr. Sargent and Dr. Lexchin. Pharmacists, I totally agree, are skilled and knowledgeable professionals, and I defer to them all the time. I ask patients to consult with them. Canadian Doctors for Medicare, however, has pointed out that just like any large-scale private for-profit elements of our healthcare system, there will be the wrong incentives. And so that can include insurance companies that select preferred pharmacies and push patients towards them, or collection of patient data for commercial use. I totally agree that, what we'd really like to see is this team-based primary care where pharmacists are part of that team. We have a stronger team that way. Moving to the questions, I really have to congratulate Brian Smith and Caroline for being very enthusiastic with their questions. I'm going to start with one from Brian, and it's if we are helping people access medication, are we also contributing to more medications entering the environment via sewage? So, for example, Prozac is in all British rivers. How does that impact safe drinking water supplies? And this question is for either of you.
So, yeah, look, both of us are obviously tentative to jump into that one, but I'll jump in. So it's the Swedish have a website that shows the impact of meds on environment, and not in the carbon footprint way, but in the way that you're talking about. And sorry, I can't quote the website there, but they do look at that. So, absolutely yes. That would be true. More meds are problematic. And I did scroll through the questions, so I'm going to combine this answer with another question, which was, I think, one of Caroline's questions, sort of wondering, well, gosh, when we're at home, we eat food and we have waste, et cetera. Like, what's the difference? So if you go around that pie graph and you look at every single thing in the pie graph, you compare home to being in hospital. We could start with building energy, which was that, the green bar, the initial green bars I showed. Per square foot of hospital, I mean, not only does hospital use much higher energy to, heat, cool, ventilate than your home, it also has much higher square footage to heat and ventilate. That's one thing. Again, I could go all the way around the pie. Look at food. Food in hospitals, we don't eat it. I mean, that's exaggerating, but we have a ton of food waste because we don't always love hospital food, right? We're not making our own food that we know and we love. So there's a lot more food waste. Medical supplies. I'm embarrassed to say, as a physician, if there's any kind of outbreak whatsoever, and I have to gown up and glove up and put the mask on to go into the room, and I go into the room, and the patient asks me a question, I think, oh gosh, I'm going to have to go back onto Epic and look to see what dose you're on that med. I'll be back in a minute. Well, if we're using single use, I'm throwing everything out, looking at the computer, come back, put it all back on again. That's the whole supply chain piece. We're probably ordering more tests. It goes on and on. We might be giving more meds because you're not sleeping well at night. So everything is just blown right up when you're in hospital compared to home. And so for that reason, again, the kilo for the ton concept. Yes, an extra vaccination has a price to pay. But keeping people out of acute care and out of hospitalization is so important. When I present in person, I always ask the question, where do you want to be when you die? And I ask people to have a show of hands. Who wants to die in hospital? Raise your hand. I've done this 30 times. I think I had one hand go up, and there's no shame in it. Some people want to die in hospital. It might be safer, it might be better pain control. Who wants to die in long-term care nursing home? I asked that at the long-term care conference in Ontario last year, and the directors of long-term care kind of looked and laughed at each other. No one put their hand up. Who wants to die at home? Most of us want to die at home. But unfortunately, 59% of Canadians die in hospital. We are aging and dying in hospitals in Canada. It's a big problem. And so if anything prevents us from ending up in a hospital, it's a benefit.
So the only comment that I would make is that right now there's a lot of inappropriate prescribing. So what we're getting is the patients are not getting good care, and the drugs are going into the environment to cause possibly harm. So if we have pharmacare with the corollary benefits that I was talking about, better patient education, better physician education, yes, drugs will still be going in the environment, hopefully not as many, and patients will be getting better care. So there's always a trade-off between giving people medications that they need and causing some harm to the environment. Our job should be to try and minimize the harm and maximize the benefit.
Thank you both. Shall we go to another question from the chat then, Edward? I can read one if you like. And for those of you, we almost certainly won't have time to get to all the questions, but if we don't get to your question, we will follow up by email with you. So I'm going to go to one from Tim Takaro. Taxpayers bought the TMX pipeline for about $400 billion after the Texas pipeline giant Kinder Morgan found the project too risky. Now taxpayers are being asked to shell out an additional $45 billion for the new Daniel Smith Marconi pipeline. These projects, of course, as we know, increase carbon emissions, temperatures, and mortality. Is there a politically viable pathway to link these misdirected funds to fully funded Pharmacare? It's an interesting political question.
right now, unfortunately, I think the answer is no. Mark Carney's vision of what's good for Canada seems to be what can you build, um, and how much oil can you transport. He doesn't seem to regard social projects as nation building ones. So, and you can see that, as I said, by the termination or the probable termination of the few Pharmacare agreements that there are in 2029. That just is not a priority for him.
Thank you, Joel. The only thing I would add to that, I think, is that generally I feel that we need to continue to promote the health and cost benefits of pharmacare. And I struggle when governments say they can't afford pharmacare when they can afford other things that are more costly and maybe not as useful. So I think this is a longer political activist game. Shall we go to another question, Edward?
Yes, sounds good. This is from Caroline. So taking advantage of the wealth of knowledge present here, two questions. The first one is, why will the 2029 pharmacare deals not be renewed for the provinces and territories with pharmacare? And then the second question is, what class of medications would you have next wanted to include?
So, why aren't the agreements going to be renewed? And this is whether or not they're going to be renewed or not. The seem it, you have to read a bit between the lines of what Carney and Marjorie Michelle have said. And Marjorie Michelle has referred to these current programs as pilots, which means that they're going to be evaluated when their funding is finished. And pilots often do not get renewed. Um, so there's no guarantee that they will or won't, but the the tea leaves seem to say that they're not going to be renewed, and they're not going to be renewed, as I said, because these kinds of social programs do not seem to be a priority for our current government. In terms of which drug I would like to see added, my vision, and this draws on a project that was run out of St. Michael's Hospital by Dr. Nav Persaud, um, and that was a project that provided a group of medication. I think there were about 120 drugs that GPs commonly initiated prescribing for. And these were largely generic medications because the really expensive ones are only available as brand name drugs and primarily used in hospitals. So for the relatively low cost of probably $2 or $3 billion a year, we could have been providing all of these 120 low-cost drugs to patients across Canada. So that's what I would like to see done.
May I jump in and respond to a few of Brian's questions? And I don't mean,
Sure, go ahead, Myles.
see Brian has a few here. I'll just see if I can do two things at once here. Brian Smith Do the inefficiencies of drug acquisition can include the recent fiasco in Alberta for sourcing children's Tylenol, stockpiling, reselling, discarding? Um, I had mentioned the fact that we have a lot of supply chain disruptions, and there would be a few reasons for this. One of them, and this gets to a question Brian asked further along. Absolutely, we should be manufacturing our own drugs, and that would solve a lot of problems, both in terms of the footprint and in terms of supply chain disruptions. So number one, we don't have domestic supply. Number two, I think we globally buy about 2% of meds globally. So when there is uh, a problem with a supply of a med, it's more likely to go to a big buyer like the States or the European Union. So that's another thing. So obviously issues there that we can't do much about. What other things were there here? Yeah, how much overprescription would you assess as a result of influencers? And that's a really interesting question too. So there's the meds that we prescribe that we talk a lot about, but then there's all the over-the-counter meds that we don't talk about, and that's billions and billions of dollars every year. That is an opportunity, as far as I'm concerned, for primary care physicians to talk to their patients. I know this is difficult, but to get people to bring in their bag of meds and take a look and see what might be actually harmful or useless that people are paying a lot of money for. So absolutely, Brian, that is a problem.
Thank you. There was a related question asking about the value of Canadian-made drugs, given the global supply chain that you've outlined, Myles. So would either or both of you like to comment on that?
Yeah, I'll just quickly say yes. I was trying to say that would be beneficial, and in fact, we run a sustainable procurement group in Ontario, and it surprises some that our partner in that group, after a couple years, is Supply Ontario, Doug Ford's Supply Ontario branch. Why are we aligned? We're aligned because Ontario, I think in part, well, large part because of Trump, has the Bobby program, essentially build in Ontario and buy in Ontario. And so when you're doing that, we have environmental laws, maybe not as strong as we might like, but we have environmental laws. We know what's coming out of the smokestacks, what's coming out of the pipes into the water. We don't necessarily know what we're buying things from other parts of the world. And then, of course, there's the transportation piece. So that is the reason we align with Supply Ontario. And so that gets to the question if we, medications as well as medical devices, it would be amazing if we could be doing more in Canada. Joel.
Sorry, I'm just getting over my granddaughter's cold. Um, but first of all, we're never going to make all the drugs that we need in Canada. There are, I don't know, between 5 and 10,000 different medications that are available in Canada right now. What we need to concentrate on, if we're going to make them, are the drugs that are most likely to go into short supply. So these are the ones that are only made by one or two manufacturers. And secondly, out of those drugs, the ones that are critical for healthcare needs. So the anesthetic agents, the the medication, the antibiotics that get used in the ICUs, so those kinds of drugs. And what we should be doing is we should be making them in publicly owned plants. You cannot rely on private enterprise to make things and that are necessary. They're working on a profit motive, And if some things are more profitable, they're going to switch to those. If the factory is not doing well, they may close the factory. So we need to make medically necessary drugs that are likely to go into short supply in, as I said, publicly owned facilities.
Thank you very much, Joel. We're almost at our time, and I do want to be respectful of people's time on a summer evening. Edward and I are going to reflect on a few themes, and then we will wrap up and invite you all also to join. If you're not a member of CAPE or Canadian Doctors for Medicare, please consider joining. Edward, what are your thoughts about the themes? And then I'll offer a couple of my own.
Yeah, thanks so much for taking us through all these insightful discussions to both of our speakers and to everyone who's joined us here. I thought it was very interesting to consider both overuse and underuse because we think about waste so much in healthcare. We forget that there's many different interventions that we're not making use enough of. And we have to think about medications as potentially polluting, but there are much better ways of using them where the benefits outweigh the harms, and expanding national pharmacare can really increase those benefits. And I think there were a couple of questions, including from Adam Raymakers, about where we should expand next. And that's a really interesting question that I'd like everyone here to think about as well. What do you think, Kathy?
I'll add a couple of things. One is that I really appreciate your focus, Joel, that with Pharmacare, we might also be more inclined to use non-pharmaceutical interventions. And among those, of course, are interventions that are good for the environment, getting, the parks prescribing time in nature. That improves people's health and also makes people more environmentally aware and hopefully more likely to advocate for our land, air, and water. And the other where CDM has been doing a lot of work pointing out the difficulties and the harms that come from privately funded care. And that's been a large focus of our advocacy. And I think that advocating for pharmacare is a really positive way to say what does work and what should work. And this is where we should be investing money, not turning to the private sector. And of course, most of our pharmaceuticals now are delivered through privately owned corporations, sometimes very large ones. So those are the thoughts I have. So with that, I'm going to just say a couple of closing remarks. When I retired, three years ago, I guess, I joined both CDM and CAPE, and I enrolled in the 6-month planetary health certificate at U of T because I believe working for a healthy environment is the most important thing I can do with my time. And retirement has shown me that I'm at heart really an activist. And of course, as physicians and healthcare workers, we're always working to make the lives of our patients better, whether as an individual or at an individual, organizational, or national level. And CAPE and CDM are both wonderful communities of like-minded people who do really good work and have a lot of fun doing it as well. Once more, I think Zarif has said this in the chat. If you are a medical student or resident, membership is free. So please consider joining. And for everyone else online, if you have the possibility to donate to CAPE and CDM, that would be wonderful. There is strength in numbers. There's a lot of work to be done in the world as it is. And I'm so happy to be doing it with people like our panelists and everyone on the line, and I really appreciate everybody's time, effort, and engagement. So with that, I will wish everyone a good evening and a happy summer.